कृपया आप लोग अपनी अपनी जगह पे बैठ जाएं। फर्स्ट एंड फॉरमोस्ट वेरी गुड इवनिंग टू ऑल ऑफ यू। आप लोगों ने इतने अपने व्यस्ततम समय से समय निकाला है। आप सभी का आईएमए की तरफ से मैं डॉक्टर प्रकाश शाही मैं आप सभी का वेलकम करता हूं। आज की सीएमई की थीम है कार्डियो न्यूरो कॉन्क्लेव, जिसमें हम एक कार्डियोलॉजी से और एक न्यूरो के टॉपिक्स को डिस्कस करेंगे। आज की प्रोसीडिंग्स क्या है वो एक मैं ब्रीफ कर देता हूं। सबसे पहले 2 सेशंस होंगे। सबसे पहले हम न्यूरो का एक सेशन करेंगे। डॉक्टर फडके हमारे साथ हैं अपोलोमेडिक्स से, और उसके बाद से डॉक्टर विजयंत का टॉक करेंगे हम कार्डियो से। तो सबसे पहले हम प्रोग्राम की शुरुआत करेंगे। उसके लिए पहले मैं चाहूँगा अपने की नोट स्पीकर्स डॉक्टर फडके सर को कि प्लीज़ एक बार मंच पे आ जाएं। डॉक्टर विजयन देवेंद्राज, आईएमए प्रेसिडेंट डॉक्टर शिवशंकर शाही, डॉक्टर आलोक गुप्ता सर, डॉक्टर सुधीर कुमार सर, डॉक्टर ओपी राय सर, डॉक्टर शांतनु अग्रवाल। सबसे पहले मैं चाहूँगा कि as we are joined by our dignitaries and key speakers, give them a big huge round of applause। इतनी दूर से आए हैं लोग और इतना समय निकाला है हम लोगों की सीएमई के लिए। आप सभी का हृदय से आभार और धन्यवाद। कार्यक्रम को शुरू करने से पहले सबसे पहले हम एज ए ट्रेडिशन जो हम आईएमई की किसी भी मीटिंग में करते हैं, मैं जॉइंट सेक्रेटरी डॉक्टर शांतनु से रिक्वेस्ट करूंगा कि आईएमए प्रेयर के लिए प्लीज़ आएँ। I request all the IMA members to please stand up for the IMA prayer. सर्वे भवन्तु सुखिनः,
सर्वे भवन्तु सुखिनः,
सर्वे सन्तु निरामया,
सर्वे सन्तु निरामया,
सर्वे भद्राणि पश्यन्तु,
सर्वे भद्राणि पश्यन्तु,
मा कश्चित् दुःखभाग् भवेत्।
मा कश्चित् दुःखभाग् भवेत्।
न त्वहं कामये राज्यं,
न तोऽहं कामये राज्यं,
न स्वर्गं न पुनर्भवं,
न स्वर्गं न पुनर्भवं,
कामये दुःखताप्तानां,
कामे दुःखताप्तानां,
प्राणिनाम् आर्तिनाशनम्।
प्राणिनाम् आर्तिनाशनम्।
थैंक यू सो मच। एज एन इंडियन ट्रेडिशन, किसी भी प्रोग्राम की शुरुआत से पहले हम लैंप लाइटनिंग सेरेमनी करते हैं। तो मैंने अपनी डिग्निटरीज से रिक्वेस्ट करूंगा कि प्लीज़ लैंप इस ऑस्पिशियस लैंप को लाइट करें और ईश्वर की प्रार्थना करें। डॉक्टर दिनेश, डॉक्टर राहुल नाथ तिवारी, डॉक्टर अश्वनी, प्लीज़ कम फॉरवर्ड। डॉक्टर BN अग्रवाल सर प्लीज। डॉक्टर दीप्ति चतुर्वेदी मैम, अब मैं अपने आईएमए के प्रेसिडेंट डॉक्टर शिवशंकर शाही बॉस से रिक्वेस्ट करूंगा कि प्लीज़ हमारे आईएमए मेंबर्स को प्लीज़ वेलकम करें।
थैंक यू डॉक्टर प्रकाश। कार्डियो न्यूरो कॉन्क्लेव में हमारे 2 विशिष्ट स्पीकर आए हुए हैं जिनका नाम सुना करते थे। डॉक्टर फडके के बारे में कहीं छिपा नहीं है। ये हम लोग का भाग है कि सर इतनी दूर से आए हैं, हम लोग को कुछ ज्ञान देंगे। आईएमए के सभी हमारे सम्मानित सदस्य जो अपने कीमती समय को यहाँ आकर दे रहे हैं, सबका मैं आभार करता हूँ। और गोरखपुर आईएमए भवन के बारे में बताना चाहता हूँ कि शायद कल एक छत लगेगी और 15 अगस्त को पूर्ण रूप से तैयार हो जाएगा, जो मैं वादा किया था। अपने टर्नओवर में किया गया, एक साथ नहीं होता, 2-2 फ्लोर किया जाएगा। तो मैंने 2 फ्लोर का वादा किया था, 2 फ्लोर मेरा कल रेडी हो जाएगा। और पाइलिंग, बाउंड्री वाल, गेट का काम चालू हो गया है। उसका वीडियो नहीं डालूँ, शाम को देकर आया था। काम अच्छा हो रहा है, क्वालिटी अच्छी हो रही है, इसीलिए डिले नहीं है। 2-3 वीडियो इतनी होती है। हमारा टारगेट तो जून में ही था, फिर उसने 10 जुलाई का दिया था, फिर 18 जुलाई हुआ, फिर 28 हुआ, फिर आज पढ़नी थी, फिर कल तो ऐसी कोई इशू नहीं है, 1-2 बस काम बढ़िया होना चाहिए और वो थरी नहीं होना चाहिए। तो इसके लिए बहुत आभार हम लोगों का। और अब एशियन में लगभग इतना ही बड़ा हाल हमारा होगा, पूरी कोशिश है। और सर लोगों का मोस्ट वेलकम, बहुत बहुत धन्यवाद। थैंक यू सर।
थैंक यू बॉस। अब without any further delay, I would like to start the first session, and for the first session I would like to invite our chairpersons, Dr. Rahul Nath Tiwari, Dr. Shantanu Prakash Agrawal, Dr. Ashwani Mishra, Dr. Santosh Kumar Singh, please. And the first speaker is Dr. R.B. Phadke sir. मैं डॉक्टर शांतनु से रिक्वेस्ट करूंगा कि हमारे स्पीकर को प्लीज इंट्रोड्यूस करें। थैंक यू।
Welcome sir. Good evening everyone. I am honored to welcome Dr. R.B. Phadke sir, who is Professor and MD Fellow Interventional Radiology, Royal Perth Hospital, Perth, Western Australia, Consultant Royal Preston Hospital, Perth, UK, Chief Consultant and HOD Interventional Radiology. He was also former Professor and HOD Radiodiagnosis, PGI Lucknow. His clinical expertise is in the field of neurovascular diagnostics and interventional works, also in diagnostic neuroradiology, MRI and CT scan. In professional experiences, over 38 years of clinical experience and more counting. Former Professor and HOD Radiodiagnosis, PGI Lucknow, Consultant Royal Perth Hospital, Perth, UK. Former President Indian Society of Neuroradiology. Former President Indian Society of Vascular and Interventional Society. Co-editor of Neuroradiology Journal before 2014. So this was his introduction in brief, and I would like to welcome sir, and we will be enlightened after his talk. Thank you.
Okay, a very good evening. I'm very happy to be here this evening and to share some of our work in neurointerventional field done at Apollo, and obviously from my previous experience in SGPGI, because we have been since SGPGI only, we have been receiving a lot of referrals and collaborations with doctors from Gorakhpur, and I'm very much thankful for that. Today, without wasting much time, I'll proceed with the topic, which is slightly more what I can say as a focused one on neurointerventional procedures. Earlier, when I visited Gorakhpur, I had discussed what is neurointervention. What it basically means is it's a minimally invasive kind of therapy for vascular diseases in the brain, which are, as you all know, in the form of either intracranial aneurysms or intracranial vascular malformations, and sometimes stenosis in the involved vessels. So what we non-invasively do is through the arterial route we reach up to there under image guidance and try to treat them in a modern way, which is less invasive, because inherently less invasive, because obviously surgically the skull is not opened up and we are going through the femoral artery route and thereby treating the lesions. For this talk I selected mainly two areas. One is the carotid stenosis, which is a very commonplace medical problem in elderly, but also sometimes happens in the younger patients. So one is related to carotid stenosis, and the other topic will be about intracranial aneurysms. Now what happens with carotid stenosis is strokes related to carotid stenosis. Just like heart vessels the vessels in the neck, especially the carotid bifurcation, is very prone to narrowing because of atherosclerotic process, which leads to progressive narrowing, and at one stage either it can dissect or can send thrombi upwards intracranially, leading to intracranial infarct and thereby causing a stroke. Now predominantly these are in elderly with atherosclerotic disease, but we can also see mentioned over here some of the problems like dissection, which is seen in younger patients, arthritis also seen in younger patients, and some of the connective tissue disorders like fibromuscular dysplasia. Then we also have post-radiation kind of neck vessel stenosis, which happens many years after radiotherapy for CA larynx. So these are some of the conditions where we may get carotid stenosis. Now to just have a quick look at what is carotid stenting, it is nothing very fancy. Just like heart vessel stentings, we are going intravascularly. Basic procedure is same. We initially go inside the artery from femoral root, selectively do an angiogram and find out the stenosis. We cross the stenosis with a microwire and then either initially pre-dilate with a balloon and place a stent, post-dilate, and that's the end of the procedure. Now although this looks very simple, what it involves is mainly 2 times dilatation, pre-dilatation and post-dilatation. Now carotid plaques, as we all know, are atherosclerotic plaques and many times soft cholesterol plaques, and during dilatation they can send some of the emboli intracranially. So which means despite carotid stenting, during the procedure or peri-procedural, we can have small infarcts intracranially. Majority of the times they are inconsequential. They do not cause any major problem because they are small, but sometimes they can cause a deficit, which is a complication of the procedure itself. Now to prevent that, we have some new devices in market, and which we are now over the last many years commonly using, and one of them is distal protection. Now distal protection means it's a filter which is something like this. This is an umbrella like filter which is placed over a microwire, and this filter is placed distally beyond the stenosis before any stenting or pre-dilatation, post-dilatation is done. Once this filter is in place, this filter allows blood flow to go intracranially, but at the same time traps any major embolic material in the mesh of the filter. So this is one major advancement that has taken place. The second major advance is the routine stents. Carotid stents, we have different stents, open cell, closed cell, and we have wall stent and many other types of stents. All these previous generation stents had micropores between the stent struts, which ranged between 300 to 700 microns, which means they still can allow some of the debris material to go intracranially and cause microthrombi. To avoid that, the new device or new stent that has developed is a double layer stent, which is known as the make is from Hester Diagnostic, and the stent itself is known as C-Guard. It has 2 layers. The outer layer is a micro mesh, again prevents microemboli, traps in the mesh itself, and this way makes the stent very safe. We'll quickly see a couple of examples. Like over here, we can see a tight carotid stenosis. This is the CT construction image of the neck and it shows a soft plaque, partly calcified, but a lot of it is soft cholesterol material. Okay. Oh, sorry. So that's the plaque over here, and which is partly calcified, but there is a soft material over here, a tight stenosis, and the distal intercarotid artery is seen over here. The procedure as I described was same, that is angiographic picture, which shows the tight narrowing in the internal carotid artery. Initially we have crossed, before that we have placed a filter. And once the filter is placed, balloon dilatation is done and stent is also placed. Post dilatation inside the stent is also done so that the stent struts are completely opened up and we have complete opening of the narrowing. Like you can see over here, the narrowed segment is completely opened up. That is the stent itself as we see it. So basically this procedure has been same, only the material has advanced and that has reduced the peri-procedural problems very much. Another example, similar example, so I won't go into details. Now coming to the other indications, like I talked about the CL larynx irradiated in the past, and patient comes with bilateral carotid artery stenosis. You can note that this is bilateral because obviously the radiation is not very selective to the larynx and the tissues around get irradiated, and in the process we have bilateral carotid stenosis. So one of these patient is over here. On one side we have stented it and that stent is seen. He came in follow-up for a CT angiogram which shows the contrast material inside and the patency of the stent. Another unusual type of indication is dissection of carotid artery. Now dissection per se can occur anywhere. Most often it is due to either trauma or underlying disease, can be atherosclerotic disease again. But sometimes these dissections are spontaneous and they can be seen in young patient. Now this patient was traveling through Lucknow, accidentally was very close to our hospital, and she had a stroke. So she got admitted to Apollo hospital, and her CT and MR angiogram followed by DSA showed carotid artery stenosis. We can see the proximal internal carotid artery over here, a tight narrowing right up to here, close to the skull base, and then reformation of the artery going inside. And you can see a thin track of contrast going along. So what essentially this means is this is a dissection, and that is the intraluminal thrombus which is hanging over here. Obviously this is a serious condition because if not treated, this thrombus can migrate intracranially and cause a major devastating stroke. So we took this patient up for stenting, and in this case used a long stent because the stenosis was very long. You can see right from here to here. After serial balloon dilatations, we have placed a wall stent which is starting from distal internal carotid to the common carotid artery. And once it was opened there, obviously like coronary stenting, here also we do it under heparinization and a full antiplatelet dosage which continue for quite some time. And that's the post-procedure angiogram which shows the arteries nearly reconstructed and the patient is doing very well. Now coming to the other topic of intracranial aneurysms. As you know, aneurysms can happen to vessels anywhere in the body, and intracranially the case is a little more special because we don't have adventitia to the vessels inside the brain, and that makes them more prone for bleeding even when they are very small. Like 2 to 5 millimeter aneurysm also can cause devastating intracranial hemorrhage. which presents as subarachnoid hemorrhage, sometimes as intraventricular or intraparenchymal hemorrhage. Now, aneurysms can be classified as ruptured, unruptured, because sometimes accidentally we detect them after doing an MR angiogram for some other purpose. So unruptured aneurysms are also found many times. Then we can also sort of classify them into wide neck and narrow neck, and that has implications regarding the treatment per se. The standard treatment of aneurysms over many years has been neurosurgical treatment, and it's today also stands as one of the important treatment option for intracranial aneurysms. The only disadvantage associated is sort of collateral damage, because one has to open up the skull, go up to the site of the aneurysm, and there can be in the process some of the problems related to either vasospasm or collateral damage to the brain. So endovascular treatment for aneurysms was came into picture, and then after ISAT trial in 2000-2002, it became a major or primary modality of treatment, unless of course there is a large hematoma which needs also to be dealt with neurosurgically. So we'll quickly see some examples, and then I'll straight away go to some of the newer devices that we are using with intracranial aneurysms. Now this is a lateral carotid angiogram of the blood vessels inside the brain. We can see the branches of middle cerebral artery in the lateral view. This is anterior cerebral artery, and we can see a tiny bleb over here, which we call as distal anterior cerebral artery aneurysm. It is hardly 2 millimeters in size, but when it ruptures, it causes significant interhemispheric hematoma and a lot of disability to the patient. So what is the intravascular way to treat such a small aneurysm? Again, we are using microcatheters which are less than 2 French, and under image guidance we are going through the artery. This is the image guidance roadmap. Under this roadmap we pass a microcatheter right up to the site of the aneurysm and deploy some electrically detachable microcoils there. Now the beauty of the procedure is that these coils are detached electrically. So once the coil is placed inside, and we are sure that it is not popping out inside the parent vessel, and it is surely located inside the aneurysm, that is the stage when we detach it electrically from outside. And depending upon aneurysm size, we may require 1, 2, or sometimes many more coils. And that is the post-procedure angiogram, which shows that the aneurysm has been taken care of, and the patients usually do well over the next few days. Some more examples like this, a double aneurysm intracranially again, and we have coiled it. These are the coils, and again this similar type of appearance or result. When the neck of the aneurysm, the part which is joining the aneurysm to the vessel wall, is wide enough, that is the time there may be some issues regarding coiling, and they are that coils may try to come back into the parent vessel, and that is where we use some of the adjunctive materials like balloon in this case. So we are putting 2 microcatheters. One is a balloon catheter. So this balloon, this is the lateral carotid angiogram, that is the posterior cerebral artery, that's the middle cerebral artery, and from this internal carotid artery supraclinoid segment we can see the aneurysm and the posterior cerebral artery like this. So this cerebral artery, unless we protect with a balloon, may get closed because of the coiling itself. So what we are doing is we have placed a balloon over here to protect the neck of the vessel, which is a normal vessel, and then with another microcatheter inside the aneurysm we have placed the coils. So that becomes a balloon assisted coiling of the intracranial aneurysm. That has been sort of routinely performed because balloon also assists us in the event of sometimes the aneurysms are very friable and they rupture during procedure. So the balloon there also takes care of a rupture. We temporarily inflate it and take care of these problems. So that's the post-procedure angiogram. That's the coiled aneurysm and the intracranial circulation filling well. Another case where this is an anterior cerebral artery aneurysm, a large bilobed one, and similarly we have placed a balloon across. That's the balloon across, and the microcatheter coils the aneurysm. That's the coil mass. Again a bilobed coil mass, and it has taken care of things. That is the angiogram afterwards, and patient did very well. Aneurysms, we normally believe that they are seen in elderly and or middle-aged people associated with hypertension sometimes, some of the other conditions. But this child was barely 11 years old, and possibly some of the vascular dysplastic conditions were associated, but he had large bilobed aneurysm coming from the internal carotid artery bifurcation over here. And we can see the vessels are poorly filling, that we call as immediate post subarachnoid hemorrhage vasospasm. So this aneurysm was again dealt with in a similar fashion with balloon. For vasospasm we have to infuse nimodipine, and that takes care of vasospasm. Now that I was talking about balloon assisted coiling, but when the necks are very wide, or if the aneurysm itself is very big and some very tricky locations which can't be possibly handled by surgery, these difficult locations need some special devices. And we have two devices which I'll show today. One is flow diverter and the other is a web device. So we'll come to that. Now what we normally do with a very wide neck aneurysm is diagrammatically shown over here. That is the parent artery in which a stent has been placed. Now this stent is placed because these coil mass, when we are coiling, the coil should not come back into the main artery. To prevent that, we have placed this stent. So this is basically known as stent assisted coiling. Now what we have as a flow diverter is, without coiling we can treat these aneurysms, and that is the new advancement on thinking of treating aneurysms. These flow diverters are also stents, but their stent struts and the holes in between are very fine. In fact, they are so fine that the first one of the flow diverter was known as silk, and there are several others now available. This is very flexible also, and it goes through a microcatheter, and we can deliver it there to sort of seal the aneurysm neck from inside the artery, leaving the aneurysm to thrombose on its own over the next few days. So that's about flow diverter, and as I just said, the occlusion of the aneurysm itself takes almost 3 months or more than that sometimes. But when it happens, because the aneurysm thromboses on its own, it shrinks and the arteries become near normal. So I'll show one example. Now this was a case we had done long back in PGI, double aneurysm into the from the supraclinoid ICA and proximal MCA in the on the right side. We can see a large one on this side, a small one on this side, and we had coiled it in 2002. It was a wide neck aneurysm, and wide neck aneurysms have a tendency to recur. And he came back, the patient came back in 2007, and there was recurrence. We can see on this side that the neck of the aneurysm has grown up again. The coil mass which is subtracted over here is pushed aside. Now this, in 2007 also we did not have this flow diverter, so we again coiled it. Some more coiling was done, and then patient presented again in 2015, when the patient was treated with flow diverter. Something like this partial recurrence at the base was seen, and we treated with flow diverter, and a 3 months follow-up angiogram here can show that the artery is now fully reconstructed from inside. We can see the 3D angiogram which shows the coil mass over here, but the artery is fully reconstructed. So that's the beauty of flow diverter, and this is progressively being commonly used. The only downside with this is we need heavy antiplatelets in this case, usually something like Brilinta and Ecosprin for quite some time, at least 3 to 6 months, and after that we can taper it down. Now cavernous carotid IC aneurysms are giant aneurysms. They are behind the eye. They are not intracranial, they don't bleed, but they can cause ocular nerve palsies, and which is a very problematic condition. So these aneurysms can be treated by flow diverter. So this is a large aneurysm in the cavernous sinus region of the carotid artery, and we can see cross flow from other side. Going back to the 3D angiogram, we can see the hugeness of the aneurysm, and these are the measurements that we have taken in order to be able to put flow diverter in this. Now if you can make out in this image, this is the flow diverter which I mentioned about, that is placed across the aneurysm neck into the artery. We can see already there is stasis and stagnation in the aneurysm. So this aneurysm progressively thromboses over the next couple of months, and the arteries get back to normal. Another condition, another small aneurysms. So this is progressively coming up for small aneurysms from large arteries like this. This aneurysm is also treated by a flow diverter. I'm not sure you can make it out from that distance, but it is very radiopaque, as we can call it. This flow diverter is over here, and which takes care of the aneurysm. Another case where we have used coils along with a CT scan shows posterior fossa mass lesion, hyperdense, and contrasted shows that there is a lumen which is enhancing. That means it's a thrombosed aneurysm partly with a partial lumen there. Angiogram shows that the V4 segment of vertebral artery is showing that aneurysm, and the best way to treat is again a flow diverter in this case, but we also did some coiling in this case so that peri-procedural bleeding does not occur. So that is the coil mass, and we can see the coil mass along with the flow diverter in the artery. That is the flow diverter, and check angiogram shows complete clearance. Now this flow diverter treatment initially was only meant for larger arteries at the skull base, means the proximal arteries. But over the years the advancements have been such that the microcatheters going much distally into the smaller arteries also can handle and take care of aneurysms beyond circle of Willis using small flow diverters. And in this case we can see a vertebral angiogram which shows an aneurysm in the posterior cerebral artery. That is the aneurysm, and we have a very kinked course over here. So the challenge is crossing that kink and delivering a stent like a flow diverter and still not getting kinked is the main advancement in the form of very supple kind of flow diverters. So that's the intracranially placed flow diverter is taking almost a 360 turn, and angiogram shows complete patency of the vessel. So in this case a Silk Vista baby flow diverter was placed. A couple of other devices which also help some of the very difficult intracranial aneurysm locations like basilar top aneurysm. Now in this case we can see a basilar artery over here. These are posterior cerebral arteries and superior cerebellar arteries. At the basilar top or the bifurcation, we can see a large aneurysm. Now this aneurysm is difficult in location because we have perforators there, surgically very difficult to access and treat. And endovascularly the main problem is we may compromise these vessels while treating this aneurysm. So for these aneurysms some special devices have come. One of these devices is a P-conus device. We can see a flower petal like device. Basically this is a stent again, but the distal end is like petals of flower once it deploys and opens up. So this is placed inside the neck of the aneurysm and deployed just to be able to coil the aneurysm without the coils popping out into the main artery. So something like this, this device was placed over here. We can see the marker of the device over here, and the petals are inside, followed by coiling of the aneurysm, and this difficult location aneurysm was coiled in this patient. That is coil mass from previous aneurysm she had in PCOM region. Now another very difficult aneurysm, a large one. One wonders like how the aneurysms can grow to this size, and but this patient had not bled, and mainly headache was the presenting symptom, although the aneurysm is very large and it has something like a bird on top of tree appearance, almost ready to bleed any time kind of thing. And again the same problem was there, a bifurcation aneurysm. So we had used a web device. Now that's the web device, which is a nitinol mesh, and this is a very soft mesh. Although on deployment this takes shape of this, shape like either quadrangle or like a sphere, but this also goes through a microcatheter tube, and this tube again we are endovascularly passing inside the aneurysm and deploying this particular device over there. That was the aneurysm at the angiogram, and as we deploy the device, you can see the device is deployed inside the aneurysm. There is stasis in the aneurysm, and this aneurysm is already thrombosing, already showing stasis. And over the next 3 months we did an MR angiogram to show that large part of the aneurysm is gone, a little bit of neck residue is still there, and we'll follow this patient up in future. Quickly go to one more case, basifrontal hematoma over here. Patient presented with hematoma and headache and vomiting. She was very apprehensive to undergo any kind of interventional treatment, and almost a month passed even after that hemorrhage before we could convince that she needs treatment. And we can see a very right angled kind of anatomy. Artery is like this, then it is aneurysm is like this. So that makes a special case for the device also. So a mini web device was placed in this case. Now that's the roadmap on which the device is advanced into the aneurysm. Here it is being deployed, and finally the device is deployed inside the aneurysm, sealing the aneurysm from inside and taking care of the aneurysm. That's the angiogram afterwards, and the patient did very well. So in short, I just wanted to show that some of the newer devices have made some of the difficult aneurysms and locations to be able to treat. At the same time, there are some downsides, like all these devices need proper handling, but at the same time we need to take care of the thrombotic tendencies of these devices, and we handle them by using double antiplatelets. At the end, I also thank for a patient listening, and also because many of these patients are from this region only, and we are extremely thankful for showing full faith in our treatment abilities and sending patients to us. Thank you very much. Thank you very much. If there are any questions, I'm willing to.
Thank you, sir. Thank you for your wonderful talk. Now the session is open for the question answer. Chairpersons.
Any questions from the audience?
Sir, what will you do in patients of Takayasu disease? Because there is diffuse arthritis.
We have treated some patients, especially those, because Takayasu can affect large vessels or blood vessels as well as renal vessels. So there is no disease that treating renal stenosis, but the vessels, carotid vessels, when we stent, obviously they have similar problems which are associated with atherosclerotic disease. In Takayasu, the more important problem is angioplasty alone doesn't work because there is a decoy and the arteries come back. And if we delay the treatment too much, the stenosis is more towards completion and it is again difficult to treat. Fortunately, the main area of affected area in Takayasu in the great vessels of arch is the common carotid artery. And as long as some lumen is there, we can stent it. One case I showed of dissection, similar type of long stent, wall stents we are using. But as you said, the main difficulty is also associated with recurrence of restenosis because of intimal hyperplasia. So we have to also treat them for Takayasu, whether it is steroids or even more like anti-malignant drugs in other times.
So, peripheral arterial disease is one of the major macrovascular complications in diabetes. And since there also the lesion is diffuse, what is your experience with stenting in these patients of PAD with diabetes, with recurrence and
Yeah, peripheral artery disease can be of different types. The type which is which we are less commonly seeing nowadays, but in our medical school days, it was very common, the Buerger's disease. It is a very problematic involvement of arteries in the sense that there is short of maybe Vijay sir can tell about any bypass strategies for that. But these vessels are very corkscrew vessels and very difficult to treat by stenting. But atherosclerotic problems which involve and accentuated by diabetes involving iliofemoral axis up to popliteal are very well handled by angioplasty and stenting. Now some institutions are also practicing distal vessel, which is more often common in the Western world, but in some of the institutions in India also, peripheral vessels are also handled by long compliant balloons. And because smaller balloons of say 20 millimeter or 40 millimeter length, if you inflate, the plaque displaces and goes to the distal part. So we need very long balloons and compliant balloons to treat them. But they are amenable, and as long as the peripheral runoff is there, we can always stent. Many times in peripheral work, we can even go to the extent of recanalizing some completely occluded vessels and crossing them to stent them. So that is possible.
One more question. You have used double layered stents for removal of plaques and aneurysm. Do you have such type of stent which have sleeve that can be used to seal up the aneurysm, just like other stents in other places. Do you have sleeved one? So that won't cause anything.
We have, we call them as covered stents or grafts, and we do have them. Normally, they are reserved for, because they are not very supple, and microcatheterization beyond cavernous sinus is not feasible with them. But till cavernous sinus, the covered stents can be used. Something like Prograf that is used for coronary work also can be used for
because larger aneurysm can be handled very easily with those.
So we have one or two situations where we have treated post-traumatic cavernous IC rupture by a covered graft stent and carotid cavernous fistulas by covered graft stents. So this fistulous communication with carotid artery and cavernous sinus also can be seen by.
So most of the time, just to aware the people कि जब भी कोई क्रेनियल इश्यूज होते हैं तो हम मोस्ट ऑफ द टाइम वो सिटी ब्रेन तक हम लिमिट करके रह जाते हैं, MRI करा लेते हैं. व्हाट आर द मेन इंडिकेशंस जहाँ पे हमें MR एंजियो या फिर कैरोटिड एंजियो जैसी चीज़ें करनी हैं? वो कॉमन इंडिकेशंस क्या हैं जिसमें आप प्रेफर करते हैं कि कैरोटिड एंजियोज करें और इन सब लीजन्स को हम डिटेक्ट करें?
Actually, the question is good because like previously when CT angiography was not in vogue or the 64 slice was not available, CT angiograms were not very good quality, not showing all the details. But nowadays the majority of the intracranial diseases and problems can be detected by CT angiogram alone. So any machine which can handle 64 slice CT machine can do a very good CT angiogram and can demonstrate almost 2 to 3 millimeter aneurysms as well. Although DSA remains the gold standard for patients in whom CT angiogram is negative. So for any patient with subarachnoid bleed or intracranial hemorrhage, apart from plain CT, and if contrast CT is done, CT angiogram should be included. So we pick up some of these lesions which may have caused the subarachnoid hemorrhage or intracranial hemorrhage. On the other hand, if contrast cannot be used because of renal condition, then we can use MR angiography also, and which also serves a good purpose to detect both the neck vessel as well as intracranial either aneurysms or stenotic problems.
And what is the correlation of carotid ultrasonography, carotid Doppler and carotid angio? Is there any discrepancy at times? Have you seen carotid Doppler is showing less lesion and you are getting more lesion in carotid angio? Is there any discrepancy?
There is a lot of discrepancy because ultrasound, as we all know, is a relatively subjective kind of modality, and it all depends on the operator. If the operator is very experienced, very good imaging can be done with carotid Doppler. But with inexperienced hand, sometimes stenosis can be missed, or it can, the grading can be either overgraded or undergraded. So objective imaging is always good when we want to offer something like a stent or any other treatment modality. So objective imaging in the form of CT angiogram, we usually perform CT angiogram from arch to vertex. So in one go and one contrast shot, we cover all these vessels which are required. Neck vessel stenosis as well as intracranial aneurysms or stenosis, everything covered in one.
Correct.
So that can be done.
Any other question? So, yes.
So what is your experience with mycotic aneurysms?
Yeah, mycotic aneurysms, although it connotes fungal, but not necessarily fungal, bacterial infections all the time cause, especially staph infections and lung infections can cause mycotic aneurysms. They are usually, as we know, they are in the distal part of the circulation, and We have 2-3 occasions where we have gone there with microcatheter, and in 1 or 2 cases we caught them, in other cases we have glued them. So glue is a sealing material which is used for AV malformations, and we have used that. Okay, Onyx is the more modern method.
With triangles or
Triangles.
the fusiform aneurysm, sir? Any your experience?
Fusiform aneurysms and fusiform giant aneurysms are again stented or used or treated with flow diverters. And some of these aneurysms can also be treated by parent vessel occlusion. If the artery is not leading to a very local area, then we can handle them by parent vessel occlusion. And sometimes we also, in collaboration with surgeons, do a distal STA-MCA bypass and then occlude the aneurysm so that there is no ischemia to the distal.
Okay, so any last message, sir, you want to communicate with our members, sir? Any last message?
No, I think imaging has done a lot of advancement in the way we see patients, because in the past always patients have refrained that मुझे extra investigation बता दिया गया, ज़्यादा investigate करते हैं डॉक्टर, ज़्यादा expenses हो जाते हैं. But I think nowadays there is no space for such an argument, because sometimes we find that the patient's symptoms are not correlating, but the investigation was done on the suspicion and high index of suspicion of the treating physician, and we have found things at the early stage. So I think we, at the cost of over-investigating patients, we should use CT angiograms and MR angiograms to detect these problems early in the stage, and which is beneficial for the patient. So that is, I think.
Thank you. I think this session needs a big round of applause. Thank you, sir. Thank you so much. So now I would like to request Dr. Rajiv Jaiswal, sir, to please come forward to felicitate our keynote speaker, Dr. R.V. Phadke, sir. Sir, please. Amit. Thank you, boss. Now I'd like to request Dr. A.K. Chaturvedi, sir, to please facilitate our chairpersons. Dr. Shantanu. I'd like to request Dr. Anju Jaiswal, ma'am. Anju Jain, ma'am, sorry. Dr. Anju Jain, ma'am, to please felicitate our chairperson, Dr. Ashwani Mishra. I'd like to request Dr. Amresh Asthana, sir, to please felicitate our chairperson, Dr. Rahul Tiwari. I'd like to request Dr. B.N. Agrawal, sir. क्विज का ये रहेगा कि हर एक क्वेश्चंस के 4 ऑप्शंस हैं. आप लोगों को अपने हाथ उठाने हैं और डॉक्टर बी.एन. अग्रवाल सर का डिस्कशन होगा कि वो किसको उठाते हैं और आंसर देने के लिए कहते हैं. आप लोग प्लीज बैठे बैठे आंसर मत करिएगा. सो द फर्स्ट क्वेश्चन इज, व्हाट कंट्री हैज द हाईएस्ट लाइफ एक्सपेक्टेंसी?
डॉक्टर अश्विनी अग्रवाल सबसे पहले हाथ उठाएं.
डॉक्टर अश्विनी अग्रवाल सर. इट्स रॉन्ग. नेक्स्ट. एनी? डॉक्टर मनीष? No, I think I should give some options now. So the options are Japan, Hong Kong, China, India. No, बैठे नहीं. So this question is invalid. अब हम ये question बेकार हो गया. अब हम next question की तरफ बढ़ते हैं. Answer is Hong Kong. So this question is, by the banks of which Indian river is the tallest statue in the world located?
डॉक्टर मनीष का हाथ पहले उठाया, मनीष का, डॉक्टर मनीष गुप्ता.
Great. A big round of applause. Please come forward. Dr. Manish, आपको एक और क्वेश्चन का जवाब देना पड़ेगा. Please come. एक बुक ले, अमित बुक. मैं डॉक्टर दीप्ति चतुर्वेदी मैम से रिक्वेस्ट करूंगा कि प्लीज. डॉक्टर मनीष, आपके लिए सवाल है, ऐसी कौन सी चीज है जिसको हम जितना खींचे वो उतनी छोटी होती जाती है? वाह, ग्रेट ग्रेट. ये बहुत ही इंटेलिजेंट बंदे हैं हमारे. वी आर रियली फॉर्चुनेट टू हैव इट. प्लीज प्लीज. ये हाँ, ये क्विज मास्टर है. ये इनसे कोई भी क्वेश्चन पूछ लो, ये हमेशा आगे रहते हैं. थैंक यू सर. नेक्स्ट क्वेश्चन इज, सो दिस वाज बेसिकली अ स्टैच्यू ऑफ यूनिटी, an ode to the Iron Man of India, Sardar Vallabhbhai Patel, which is located at the banks of Narmada River in the Kevadia colony, facing the Sardar Sarovar Dam in Gujarat. So the next question is, what is the fourth letter of Greek alphabet? Dr. Dinesh Singh. So yes, this is the right answer. Please come forward, Dr. Dinesh. So the letters of the Greek alphabet are alpha, beta, gamma, delta, epsilon, zeta. I would like to request Dr. Ashwani Agrawal sir to please give the token of appreciation. Thank you sir. So the next question is, which planet has the most moons?
Dr. Aloke sir.
Dr. Aloke. Aloke sir. नहीं, बैठे बैठे नहीं करना है, ये क्वेश्चन गलत हो जाएगा. जुपिटर इज रॉन्ग आंसर. बैठे बैठे दिया तो गलत हो गया, सर का डिस्कशन रहेगा. सो दिस क्वेश्चन इज इनवैलिड. विल मूव टुवर्ड्स द नेक्स्ट क्वेश्चन. सो द करेक्ट आंसर इज सैटर्न. Saturn is having 82 moons and Jupiter is having 79 moons. So this is interesting one. Most specific symptom of temporal arteritis. आपको हाथ रेज करने हैं, हाथ रेज करने हैं. So this is the right answer. Great. Big round of applause. Please come forward. I request Dr. Kanu Verma to please hand over the token of appreciation. आप यहाँ पे आ जाइए डॉक्टर साहब. यहाँ इधर सामने. Big round of applause for Dr. Rahul. The correct answer is jaw claudication. So giant cell arteritis is a temporal arteritis, is a chronic vasculitis of large and medium vessel arteritis, usually affecting the cranial branches of arteries arising from the aortic arch. Jaw claudication is an underreported yet a very specific symptom of giant cell arteritis with a high positive predictive value. So the question is, what year did the Titanic sink in the Atlantic Ocean on the 15th April on its maiden voyage from Southampton? You have to raise your hand. Dr. B.N. Agrawal sir will select which. 1912. That is the right answer. Please, doctor, please come forward. एक बार आके आप अपना प्लीज परिचय दे दें. देखा था टाइटैनिक. आप प्लीज अपना परिचय.
मैं डॉक्टर सुमित प्रकाश, मैं चेस्ट फिजिशियन.
डॉक्टर सुमित प्रकाश के लिए जोरदार तालियां प्लीज. मैं डॉक्टर सीमा साही से रिक्वेस्ट करूंगा कि प्लीज मैम कम फॉरवर्ड एंड big round of applause. Thank you so much. So this is the end of the quiz. Thank you so much. So for the next session, I would like to request our chairpersons. We have a very eminent chairperson for this session. I would like to request first Dr. This session. I would like to request first Dr. Sir is a well-known fraternity in our IMA. इनको किसी परिचय की आवश्यकता नहीं है. He is a president of UP Diabetes Association, faculty PHFI. He is a member time in Range Academy in IDC USA, consultant Diabetes Education and Research Center, Gorakhpur, UP. Next, our chairperson is Dr. Sudhir Kumar sir. सर को भी किसी परिचय की आवश्यकता नहीं है. जितनी शायद हम लोग एक साल में CME कराते हैं, सर वो एक महीने में ही करा देते हैं. Thank you, sir. Thank you, sir. We are very privileged to have you here. Next, our chairperson, Dr. O.P. Rai, sir, senior physician. He is MBBS from BRD Medical College, Gorakhpur, and he done his MD from General Medicine from SN Medical College, Agra in 1985, sir. Thank you, sir. Thank you for coming and gracing this occasion. And next, our chairperson is Dr. Dinesh Kumar Singh. He is the young, very, very dynamic cardiologist in Gorakhpur, currently practicing in his own clinic and associated with Shahi Global Hospital. Now, the speaker is Dr. Vijen Devenraj, and I request Dr. Sudhir sir to please introduce our speaker and the topic. You have, sir?
So we have got very eminent speaker for the topic recent advances in heart failure and in cardiac surgery. Dr. Vijen Devenraj. He was formerly Professor CTBS at King George Medical College, Lucknow. He is MCH in cardiothoracic and vascular surgery. And to summarize some clinical expertise, he is expert in beating heart coronary artery bypass grafting. He has got expertise in heart valve replacement, maybe mitral valve, maybe aortic valve, maybe double valve, or even tricuspid valve. Then congenital heart disease surgery, ASD, VSD, TOF or PDA. Then minimal invasive cardiac surgery, which is a trend now. Then TAVI, that is transcatheter aortic valve implantation. Lung surgeries, aortic surgeries, and vascular surgeries. His professional experience is over 16 years with more than 5,000 successful cardiac surgeries. He is first in our state to successfully perform TAVI in private setup. He is former faculty and associate professor in the Department of CTBS, that is Radi Cardiology, KGM in Lucknow. He is part of the team to perform first LV assisted device implantation in our state. He is ECMO expert and pioneer in this field. That is all about Dr. Vijen Devenraj. We have got some more, but since we are running short of time, so I will request Dr. Vijen to kindly come and deliver his lecture.
A very good evening to everyone. Thank you IMA Gorakhpur for inviting us from Apollo Hospital, Lucknow to deliver our lectures, and a very warm welcome to the chairpersons and to all the delegates present here. So as we are running short of time, the topic given to me was to discuss on recent advances in heart failure as well as cardiac surgery. So I'm Dr. Vijayant and did my MCH from KGMC, and then I worked as faculty for around 8 years over there, and now I am as senior consultant at Apollo Hospitals, Lucknow. So as you see over here, I'll brush through a lot of slides. I'll not go into the details. What I want to tell you is what are the recent advances and how to go about them to make it short and maybe interesting for everyone. We all know there's a definition for heart failure, and there are different types of heart failure, and we all believe heart ejection fraction less than 35% constitutes a heart failure for all of us. There are various subdivisions in which there are HFrEF patients, there are heart failure with mildly reduced ejection fractions, and will preserve his extractions. Then these are the new onset and chronic, and then we have the right side and the left side, and we have acute and stable and chronic heart failures. So we see this burden is very, very high of heart failure all across the globe, and we see a lot of hospital funds going into this because a lot of mortality. A 5-year survival of is very less in patients of heart failure with reduced ejection fraction, and recurrent hospitalization is the norm rather than an abnormality. A lot of diseases contribute to heart failure. We have valvular heart diseases, especially the regurgitant ones. Then the pericardial diseases, high output states, volume overload, myocardial diseases, coronary artery vascular diseases, endocardial diseases, various arrhythmias. So we see, and a lot of congenital heart disease. So we see a lot patients who develop heart failure. And then the comorbidities, we see that a lot of patients do have comorbidities. Why are they important to take in consideration is that because what happens is a lot of drugs do interact. These patients are having a lot of comorbidities, and so in this scenario we have to take care what are the comorbidities. Now we all know what the management is. The first line management for any heart failure will be a drug therapy. That's a guideline directed medical therapy. Then there is the acute heart failure for which the CRT is given. IBP, ECMO and Impella devices are there. And for chronic heart failures, these are the left ventricular assist devices, biventricular assist devices, there's the right and the left, and then we have the heart transplant. So we all know that we start from a medical therapy, and then the destination therapy is the heart transplant. The problem with the heart transplant, even though the good news is that at Apollo now we have the license for a heart and lung transplant with us, but the problem is not about the patients. We have a lot of patients who are into heart failure. The problem is about the donors, and the donors are scarce, very, very scarce. We have to have patients who are brain dead. We have to have patients whose heart is functioning good, so that we can go for a costly procedure with immunosuppression. And then a very important part all over the world, especially more in northern part of India also, that to counsel the patients to donate the heart. That's not an easy job. So so what's the interesting part and what are the recent advances? Like we see that the drug therapy was the initial part, and then the destination therapy was the heart transplant. So there has to be something in between. The big mismatch between the availability of donor and the patients with swelling numbers of heart failure is where the problem lies. And so we had these many devices, and over a period of time now we have the third generation devices known as the left ventricular assist device. I want to know more about that, but just a brief. These are various drugs. I know most of you have been practicing these drugs. We all start with diuretics, ACE inhibitors. The new ones are the ARNIs and the SGLT inhibitors. They are found to be very good for patients, and obviously all the patients before going for any invasive technique should be given a full chance for have a guideline directed medical therapy and the most optimal medical therapy. Then we have patients who have very low ejection fraction, less than 35%, white QRS complexes, and these are left ventral branch block. Then these are the patients, and maybe these patients go into recurrent fibrillations and arrhythmias. Now for these cardio resynchronization therapy is very important. We have a device over there, and that gives it's more like a pacemaker, a dual chamber pacemaker. What it does is it conducts the electrical conductivity very nicely, and so the heart does behave very nicely. A lot of these devices come with a ICD. These are the defibrillator devices, so that we know that these patients have a lot of sudden deaths. So these patients we are able to prevent these patients from sudden deaths. Then intra-aortic balloon pump. These are mostly used in acute conditions in post-cardiotomy patients or patients with severe MI, refractory. Now for all this, what we do is we use an intra-aortic balloon pump. We put them through a femoral artery, place them into the thoracic aorta just below the left subclavian artery. What they do is that they augment the diastolic coronary blood flow. It increases the myocardial oxygen perfusion and indirectly increasing the cardiac output. And the systolic decompression when it relaxes. These are balloons. They are filled with helium and they decompress, they inflate and deflate. So when they deflate, the heart does not have to work. They are normally In adults, we use a 40 cc of balloon. So an ejection fraction which is very poor. When they deflate, they create a void of 40 cc. Now this is where the heart does not have to work more. And then at time of diastole, well, that's the time when the coronaries get filled up. We have these balloons that inflate. Now they push the extra blood into the coronaries, therefore increasing the oxygen demand, oxygen available to the myocardium. These are devices that are used in acute conditions, acute heart failures. The impeller device, again these are implantable devices. A few of the devices are being used for long term or mostly are for short term. A lot of centers are even using them for doing very complex coronary stentings in patients who are whose general conditions are very poor, who are having poor ejection fractions. So what they do is they take out blood from the LV and they push it into the aorta. And after the procedure is done, these devices are taken out. A lot of talk about the ECMO has been there. I guess with the COVID pandemic, we all know patients requiring ECMO. So we are the guys who put the patients on ECMO. We have been doing this. ECMO has been a very, very old thing, and at KGMC we put 2 patients on ECMO. And with the but all these patients were post-cardiotomy patients. That was after surgery. Mostly the pediatrics, congenital heart disease do require ECMO, but sometimes the adults would require an ECMO so that the heart function comes. Now these are the patients who are put on VA ECMO. That's the venous artery, the blood is drained from the venous side and put into the aortic side, be it from directly into the aorta or through the femoral artery. For all COVID patients, this was not the scenario. These patients would be requiring a lung, arrest to the lung. So to give rest to the lung where the oxygenation is very poor and these patients do accumulate carbon dioxide, the VV ECMO was used. So these are there with COVID, a lot of use of ECMO has been there. So a VV ECMO was placed in all these patients, would take out blood from say the IVC and then give it into the SVC at the junction of the tricuspid valve. So there would always be some mixing of blood, but yes, the lungs would get rest, the heart was always good, and these are the patients who with time are expected to work. These are not therapeutic, they are only to give rest. The VV ECMOs in ECMO in COVID patients were supposed to give rest. They were not therapeutic, and we have fair good results. We put 5 patients, we were able to save 2. It is a very, very costly affair to go about. A lot of insurances there has to be there to go about this. मेरा सारा इंटरेस्ट था आप लोग को एलवैड दिखाने में. ये डिवाइस है एलवैड. हार्ट फेलियर डिवाइसेस में पहले जब पेशेंट को हम लोग वी यूज्ड टू हैव अ बिग मशीन आउटसाइड, 2 पाइप्स कमिंग. नाउ दिस इज अ मशीन, एलवी पे वो मशीन लगा हुआ है. दैट्स द लेफ्ट वेंट्रिकल एंड दैट्स द असेंडिंग एओर्टा. नाउ दिस इज HeartMate 3 दैट वी आर सीइंग ओवर हियर. इट्स अ कॉस्टली डिवाइस कॉस्टिंग अराउंड 90 lakhs. That's the titanium over there. It has a centrifugal pump. What it does in a failing heart is that it will take out blood. This is all titanium. We fix this over there and it gets into the blood is taken out from here. Levitation पे ये work करता है, इसलिए thrombosis होने का chances बहुत कम होता है. यहाँ से blood आता है और वहाँ से aorta में चला जाता है. So now this is where it decompresses the heart. Now this is the therapy that I wanted to tell you. It has a motor drive. It only has batteries outside. So the whole of the system gets inside. It is not, nothing is outside. This pump cable and the modular cable will come out and this will get attached to a small bag in which you have batteries. You are given around 4 sets of batteries, a charger and everything. This is the latest and the most advanced form of thing this patient has been put in, and we have to keep very clear this is a drive chain that has been put out. So these patients work very nicely. Now these are the devices. In the initial time what happened was that these devices were taken as bridge to transplant. They were not the ideal things. Now these are the devices that are being considered as the destination therapy. Now they have been many studies. Now HeartMate 2, a lot of studies that showed that it was working for more than 10 years, 8 years. Now this is the NEO device, much better device. Centrifugal pump with levitation technology, costly no doubt, but yes, these are being put in India and patients are doing very well. So a 10-year of life in a heart failure patient, what happens is that these are now become an alternative to heart transplant. Anyways, these are not the alternate to heart transplant, but yes, for the scarcity of the organs, this has become to be as considered to be as destination therapy. Now this is what my interest was. Heart transplant, yes, we have the license, waiting for the right time to go ahead with the heart transplant. It will take its time, but yes, it has been in there. The transplant has been there for ages now, and let us see if we can go ahead with that. In Uttar Pradesh, there has been no heart transplant till date. So that was a short, and my interest was to show you some video about how the left ventricle devices have actually evolved. Then minimal invasive surgeries. Now these are the routine rather than new technology. Over the period they have evolved. A lot of surgeons are taking up to them. We do not go through the midline. We use a small scar on the right side or the left side, and it reduces the post-operative pain. Cost message is very, very good, faster healing, and return to work is very important. For all Indian females who have ASDs that cannot be closed by devices with insufficient rims, then mitral valves, aortic valves, VSDs, all these patients we operate from the right side, and then so these are the patients that go and do. So we have already done around 105 cases of mixed ASDs, and we extubate all these patients on table. Now the surgery and the drain and everything are so less through this. The pain is so fast and the patients recover so fast that we are able to send the patients home the very, very next day. So this is where the aorta is, and we have opened up the chest from the right thoracotomy. This is the fenestrated ASD that you can see over there. That's the fenestrated ASD. I'm not using a marker. I don't know if it will work or not. Then we close this. I started this at KGMC, and there was a wide media coverage, and we were the first ones before PGI even to start this at our center, and I initiated, and now we can very well understand that a lot of centers are doing that. At the same time, we see this, we have started sending the patients, extubating them on table, the drains out in the evening, and sending the patients the very next afternoon. So you see this is how, now this is a young female we see over here, who the ASD has been closed at Apollo hospitals. A scarless young female, that's all that they want. Minimal MVRs and minimal AVRs, a lot of patients we are doing over them. This is a mitral valve replacement. Over there you see a mechanical prosthetic St. Jude's valve being put in the left atrium, and that's a small scar over there. So at Apollo we continued, and we have done a lot of cases of minimal MVRs over there. So then again a challenge came to us with a patient who was severe COPD. And this is the patients when we thought that we can actually go with a very high cervical block, will not intubate the patient during the open heart surgery. Did a midline sternotomy for this patient. We had to be very careful so that the pleura would not open, and there are a lot of other technicalities over there. And then this patient remained awake throughout his surgeries and was sent home very nicely. I'll try to run if... I don't know how to forward. So these are few things that we can do sometimes, and patients do very well. And this is the patient Abdul Kalam. He was from Gonda, I guess.
सांस बहुत ज़्यादा फूलती थी, लेट भी नहीं पाता था, दो तकिए लगा के लेटता था, और जरा सा भी चलने पे बिल्कुल सांस उखड़ जाती थी, सांस में लेने में दिक्कत हो रही थी। जब हमने इको कराया तो पता चला पेशेंट को सीवियर एओर्टिक रिवैल्यूएशन है, मतलब दिल का एक वाल्व जिससे पूरे दिल में शरीर में खून जाता है, वहाँ पे खून वापस रेस लगा था। पूरा एसेस किया तो पता चला कि इसकी फेफड़ों में भी ताकत कम है। ये हुआ इनको यहाँ पर आए, इनको ऐसा फील हुआ कि हम यहाँ सही सेफ है या हमें रिलीव है यहाँ पे हॉस्पिटल देखे। Then we decided कि हम इसमें एक जागता हुआ ऑपरेशन करेंगे, अवेक AVR करेंगे। मतलब पेशेंट जगता रहेगा, बात करता रहेगा और पेशेंट को कभी भी वेंटिलेटर पे हम लेंगे ही नहीं. इसमें जो पल्मोनरी फंक्शन है,
दिस इज द पेशेंट ओवर हियर.
ऑपरेशन के दौरान
ही इज अवेक, अपनी जीभ दिखा रहा है.
जगह रहता है.
दिस इज द पेशेंट, हमने रिप्लेस कर दिया. द हार्ट इज देयर, इट्स बीटिंग. दैट्स आवर टीम ओवर देयर. That's our team over there, and that's a heart lung machine. जब open heart करते हैं, there's a perfusionist and he's the cardiac anesthetist, and we can see that the patient has come off the bypass. So these are the rare cases that you have to pull up sometimes, and they do very well, and that is how it went off very nicely. So over here we are with our chairman, Dr. Gattani. He is no longer with us. We lost him. But yes, this was a team that performed the. Then TAVI, I guess, cardiologist over here, they would know it. That's a transcatheter aortic valve implantation. Now what we do is, for patients who are surgically very, very down, cannot go for a surgical valve replacements. This is indicated in those patients. Not in all the patients. Still, the surgical valve replacement remains the gold standard, be it biprosthetic valve or mechanical valve. But yes, patients whom we think that can live for 5 to 10 years, very weak to undergo a surgical open heart surgery, have to be given this choice, and we performed this at Apollo. And again, this was a video over here. I'll try to put it. What happens in this transcatheter aortic valve implantation is that we go through the femoral route. We use a valve that is a bioprosthetic valve, crimp it so that it goes into the femoral artery. Through the femoral artery we go up, reach up to the aorta. So this is how it goes up. We put in a wire, we go into the aorta, and this is a calcified valve. The indication is for aortic stenosis rather than aortic regurgitation, and now this is how the valve has been put over there. So again, these are the techniques. This is the patient. She was 72 years, very, very weak, and we see her over there, and she went home very nicely. So that is all what gives us our part. Then coming to a newer thing, it's not a newer thing, but yes, it is getting its space. Now we are doing for all the patients, we are offering a TAR CVG, that's total arterial revascularization. So, we see this, I normally use Lima Rima Y for all the patients. And I do not, I stopped using vein for any patient. We see in this patient, the Lima is anastomosed to the LED, and in the video we can see that it goes, the Rima goes behind, reaches up to the OM, and then goes up to the PDA. So this is how the patients do the surgeries. Then a new thing that is we are doing is that we have started doing minimal invasive bypass surgeries also. Right now we are doing this for the left vessels, and we say this is the patient over there. He had a stent in his LAD, and we have around performed 5 patients. This is a small scar, and you can see this patient, the left side scar. This is the only scar that the patient receives, and the patient goes home very well. Put in a grafts and do not open the chest, and this is done on a beating heart. So we have already done 5-6 cases, planning more with due course of time. Then a lot of cases, LA myxoma in 85 years old male, then CABG, post-MI ventricular septal rupture. Not many patients go home. This patient was lucky to go home, was a very poor ejection fraction of 25% with VSR, and this patient went home. Working in a hospital with super specialization, we see this, that we have a MRM along with a LA myxoma operated over. Then RTAs, being from institute, we see this, a lot of patients come to us. He was a doctor from Allahabad and had multiple refractures. Even with the best painkillers, you could not wean him off the ventilator. So taking up, I do a lot of thoracic surgeries, and this is how we fix the ribs, and the patient was gradually weaned off the ventilator and sent home. Then congenital heart disease, we do a lot of ASDs, VSD, the regular ones. Apart from that, we do a lot of tetralogy of Fallett's, and we do in the kids. So redo MVRs, this patient was operated at AIMS, and we can see a degenerated valve over here. So we see this, the valve is totally degenerated over there. We took out this valve. The patient also had LA clot, was operated in AIMS. I don't know why was a biprosthetic valve put in such a young patient. Maybe for for starting a family or something, that would have been the only indication. But still, I don't know why was that put. It was very becomes very risky to redo surgeries in these patients. This patient did very well, went home nicely. Then one of the rare cases, congenital CHP. This patient was from Guwahati and was diagnosed wonderfully. I don't know how was wonderfully diagnosed, very well in Guwahati, that the patient is having a CHP in utero. So this patient flew to Lucknow, had the relatives in Lucknow. So when the child was born, we immediately we had to take the patient up and put in an epicardial pacing wire. To do that in a say hours of child, that was 8 hours when we did 8 to 12 hours of birth, that we did our surgery for this. Now this is a child who is 6 months now, came to us in the OPD doing very well. So mostly all these patients used to go to Gangaram for all these procedures, but we have been doing this procedure. Now this is less than 1 day old child that we have put an epicardial pacing wire. Bentall surgeries we are routinely doing over here. Now Dr. Phadke is here. So the complexity of tetralogy of Fallot is not when we do it in a child. The complexity starts when we do it in adult. So this is where the MAPCAs develop. And these are the major aortopulmonary collaterals that developed in patient who has severe pulmonary stenosis, valvular, infundibular, whatever. So what we do is, Dr. Phadke sir, we do it in the same sitting. Phadke sir takes the patient into his cath lab. He does all the coiling of all these patients. This is one patient and this is another. Now in this diagram you can see a lot of coils over here. Now these are the coils that have been put by Dr. Phadke sir. At the same sitting, as we put on the coils, the patient starts to desaturate, because this is the only source of oxygen that the patient is getting, oxygenated blood. So we intubate the patient, then after coiling is complete for major, then we take the patient up 2-hour OTs and do a complete intracardial repair. And these are the results in the outdoor patient department. The patient is having 99 saturation during the follow-up in a TOF patient of adult patient. That is all that is required. Again, this is guy who is again having 99 saturation. Living in UP, gunshot and all these things tend to be common. We cannot do away with them. So this was a patient, had a very close, you can see in this CT, this bullet has totally shattered the lung of this guy. So we can see the only saving grace was the heart was saved. It did not run through the heart. It was shot at very short blank range. Scooty ke agal bagal se mara tha dosti yaari mein hi. We can see this bullet, and again this patient had this bullet. It was placed inside the lungs only. Operated this patient, and now we can see this was this is where the bullet went in, and the other side it was all came out. Now we can see this patient in the OPD. Now he's the same guy who is there smiling in the OPD with a gunshot injury and going home and coming back for the OPD. So international patients, one did CABG in patient from US. He did not come to me to get his CABG done. He was incidentally in Lucknow and had a chest pain and was found to have a severe left main disease. Operated this patient, went home to California after the surgery, did all his regular investigations, was found to be good, and has been sending his photographs. And patient from Iraq, he came to get his operated, then patient from Nepal. So doing patients from here and there, and I'm speaking for my team actually. It's not me who's doing all this, it's a team who does all this. It's always a teamwork. CTVS is completely a teamwork approach. So with your blessings, we have a lot of blessings from Gorakhpur, and we are doing all sorts what the patient and the surgeons were doing very nicely in Delhi or Mumbai. So we are trying to give that to our patients of UP, within UP. So a lot of government schemes are there, so the patients do get benefit a lot. Thank you. Thank you for patience. Short kar dete hain.
I request our chairpersons to please come on the dais for the discussion. So, आपने बॉस मुझे बड़ा कंफ्यूज कर दिया कि टैबी आप कर रहे हैं, इंटरवेंशन डॉक्टर फटके कर रहे हैं, कैरोटिड एंजियोप्लास्टी वो कर रहे हैं, तो आपके कार्डियोलॉजिस्ट क्या कर रहे हैं?
See, TAVI is once in a while. We all know.
मैपकास की कोयल एम्बुलाइजेशन आप लोग कर रहे हैं?
नहीं, हम नहीं कर रहे. फटके सर कर रहे हैं. Yes.
आप दोनों लोग मिलके कार्डियोलॉजिस्ट का काम खराब कर रहे हैं?
नहीं, बिल्कुल नहीं. I always believe, say, TAVI and all these are things, but the main thing is heart team concept that is coming up for heart failure. that's a thing that is really we have to look on to as a team.
So the session is open for the discussion. Boss.
अब तक कितने डिवाइस आपने लगाए होंगे?
सर जोक्स अपार्ट
एक डॉक्टर गगन, हाँ,
एक चीज पूछनी है. If a patient of aortic dissection underwent Pental's procedure with bioprosthetic valve, he is due for bioprosthetic valve है तो he is due for repeat surgery after 18 to 20 years. Whether he has to go for open heart surgery or TAVI will suffice if the original bioprosthetic valve was 25 mm.
Yeah, that's a great question.
That's a great question. I think it all depends कि जो valve लगाया था वो TAVI acceptable है कि नहीं है. I guess Edwards अब valve निकाल रहे हैं जो कि TAVI acceptable हैं. और most of the valves अगर आप बोल रहे 25 साल पहले लगा था, maybe 10 साल पहले भी लगा था. अगर बेंटाल हुआ है तो वो वाले valves TAVI acceptable नहीं थे, तो आपको redo surgery के लिए ही जाना पड़ेगा. There is no other option. Open heart surgery है. Redo open heart surgery. जैसे female का MVR हुआ था. So we have a valve in valve, that is जो आप पूछना चाह रहे हैं इसको हम valve in valve कहते हैं. पर ये वाले जो valves अभी आ रहे हैं ये fully TAVI compatible नहीं है. So अभी Edwards जो कंपनी है उन्होंने निकाले हैं valves. ये valve को जब भी आप लगा देते हैं उसके बाद भी अगर हम चाहें TAVI में जैसे हम expand करते हैं अपना valve बैठाने के बाद, तो वो expand करते हैं चाहे माइट्रल पोजीशन है aortic पोजीशन, उसको थोड़ा सा stretch मिलता है. ये वाले valves में ऐसा नहीं था. struts और stents इन वाले valves के compatible नहीं थे पहले वाले valves के. अब जितने भी valves आ रहे हैं इनको ऐसा compatible देखा जा रहा है.
I was studying literature somewhere. If the original valve was more than 20 mm or 23 mm and conditions permit, then whatever valve may have been placed, we can assess for TAVI.
नहीं, अभी ऐसा इतना क्लियर नहीं है. जो नए valves हैं वो डेफिनेटली हैं. पुराने वाले valves को देखना होगा कौन सा लगा है, उनका प्रोफाइल कितना हाई है, कोरोनरीज तो नहीं पकड़ में आ रही है. We have to really assess the case.
Yeah, definitely. TAVI has some limitations. Bioprosthetic valve degenerative, if there are, then these are the indication at present scenario. But as you are saying, the valve is of older generation, then it might not be going for the TAVI. Yeah. So,
Sir, TAVI normally around 18 lakhs, 19 lakhs cost करता है. अच्छी बात है इंडियन कंपनी भी बना रही है जो कि रेट थोड़े से ज़्यादा एडजस्ट कर लेती है. मोस्टली ये जो अभी आ रहे मेट्रॉनिक्स के आ रहे हैं जो ज़्यादा लग रहे हैं, पर इंडिया में मेरिल के ज़्यादा लग रहे हैं. ये गुजरात बेस्ड कंपनी है जो कि वापी में इनकी फैक्ट्री है. सो दे आर यूजिंग valve that is good and let us see. It is बस एक बार याद रखना है कि लेस इन्वेजिव से ये नहीं सोचना है कि ये ट्रीटमेंट ऑफ चॉइस है. ये ट्रीटमेंट ऑफ चॉइस है 70 प्लस एज में, वो भी जो कि एक्सेप्टेबल नहीं है. सर्जिकल रिस्क बहुत ज़्यादा है. It still stands that the surgical valves do remain the gold standard for surgical treatment for aortic valve replacements. It is a costly procedure. With time जितना यूज होगा, I guess it will come down. सर ने पूछा था एलवैट के बारे में. सर एलवैट अभी हम लोगों ने नहीं लगाया है यहाँ पर. ये ज़्यादातर दिल्ली में लगे हैं और कुछ मुंबई में लगे हैं. We have one patient who we are working up from Riyadh. So this will for international patient ये 93 lakhs का पड़ता है. For Indian patients around 82 lakhs का पड़ता है. They have their own ideas ये ऐसा क्यों है. पर मैं अगर आज की तारीख में देखूँ तो मेरे को ये डेफिनेटली एक bridge to therapy से ज़्यादा लगता है कि it is for patients 10 years of life with severe heart failure and they got good life, quality of life is good. आप नहा भी सकते हैं, सब कुछ कर सकते हैं. तो this might be a destination therapy or maybe an alternative therapy to heart transplant.
Thank you.
So any other questions? कोई भी क्वेश्चन कार्डियक सर्जरी से रिलेटेड है तो आप लोग पूछ सकते हैं. डॉक्टर विजेंद्र.
बाकी
बॉस एक मेरा क्वेश्चन है, ये किलोइड की प्रॉब्लम बड़ी होती है ये पोस्ट सीएबीजी में, तो हाउ डू यू मैनेज दीज पेशेंट्स?
Reason for keloid is the midline. It's not about CABG or anything. आपका कोई भी स्कार सर से लेके पैर तक मिड लाइन पे जाएगा. That is how we are in the mother's womb. तो हमारा जो बदन बनता है वो ऐसे बनता है. So that is how the keloid is there. Newer studies have come in. अभी हम लोगों ने काफी स्टडी करी तो we have decided कि वाइक्रल जो पर्पल कलर का आता था जिससे कि सबक्यूटेनियस टिश्यू लगाया जाता है उसको व्हाइट कलर पे लगाते तो keloids कम होते हैं. There are a lot of therapies that we are trying to put in, but yes, keloid is there. वो मिडलाइन स्ट्रक्चर के कारण है. वो हमारी सर्जरी बिल्कुल ही मिडलाइन से होती है इसलिए है. अपार्ट फ्रॉम दैट अ लॉट ऑफ सर्जरीज जो भी मिडलाइन से keloid propensity उनकी रहती ही है.
Right. So I think this was a great talk. I think Dr. Vijan need another big round of applause. Thank you, sir. Thank you. We are really privileged to have you, sir. Thank you so much. And in the last मैं चाहूँगा डॉक्टर AP गुप्ता सर से रिक्वेस्ट करूँगा कि हमारे की नोट स्पीकर को फेलिसिटेट करें. मैं डॉक्टर रोशन झा से रिक्वेस्ट करूँगा कि प्लीज़ फेलिसिटेट करें हमारे सीनियर फिजिशियन डॉक्टर OP राय सर को. मैं अब रिक्वेस्ट करूंगा डॉक्टर गगन गुप्ता से प्लीज़ डॉक्टर आलोक गुप्ता सर को फेलिसिटेट करें. मैं डॉक्टर प्रतिभा गुप्ता मैम से रिक्वेस्ट करूंगा कि प्लीज़ हमारे डायनामिक कार्डियोलॉजिस्ट डॉक्टर दिनेश सिंह को फेलिसिटेट करें. थैंक यू मैम. थैंक यू डॉक्टर दिनेश. मैं अब प्रोग्राम के लास्ट में डॉक्टर BN अग्रवाल सर से रिक्वेस्ट करूंगा. डॉक्टर BN अग्रवाल सर प्लीज़ प्रपोज अ वोट ऑफ थैंक्स.
सबको मेरा नमस्कार है. सबसे पहले मैं धन्यवाद दूंगा अपने PC शाही साहब को. इतना कर्मठ सुयोग हैंडसम साइंटिफिक सेक्रेटरी IIM को आज तक नहीं मिला था. हाँ, कर्मठ हैंडसम दोनों ही हैं. और इसी की वजह से मुझे लगता है इनके प्रयासों की वजह से ही हम लोग यहाँ आते हैं. वरना CME तो IIM के अलावा बहुत जगह होती रहती है. आपको वहाँ पे 5, 7, 10 लोग भी नहीं मिलते हैं. बाहर से आए डॉक्टर फटके सर और डॉक्टर विजयंत, आप लोग समय लेके यहाँ आए. आप लोगों को सर पूरे गोरखपुर IIM की तरफ से सलाम है. हमारे सीनियर्स जो समय निकाल के चेयरपर्सन के रोल में यहाँ पे थे, उन्होंने सबको इन्वॉल्व रखा. उनको भी IIM की तरफ से धन्यवाद है.
मैं अपने प्रेसिडेंट को डॉक्टर शिवशंकर शाही को प्लीज़ एक बार यहाँ पे इनवाइट करूँगा. मैं डॉक्टर BN अग्रवाल सर से रिक्वेस्ट करूँगा कि हमारे प्रेसिडेंट को फेलिसिटेट करें.
OP राय सर मेरे भी गुरु हैं, मेरे कॉलेज सीनियर भी हैं और सभी होंगे. हमको प्राइमरी स्कूल की तरह पढ़ा रहे.
थैंक यू ऑल IIM मेंबर्स. आप सभी का यहाँ पे समय देने के लिए मैं हृदय से आभार व्यक्त करता हूँ. आप सभी को डिनर के लिए इनवाइट करता हूँ. थैंक यू.